funded programs that provide comprehensive HIV care for folks regardless of their ability to pay. And not only do they play a really strong role in helping people with HIV access medications and all the care and treatment that they need, they also really support HIV prevention efforts in ways that we can discuss as well through helping people maintain virologic suppression. I have a strong interest in linkage and retention and care and HIV care, and have done some work through people who've been involved with our carceral system, which is how I met Tiffany long ago. So meaning people who've passed through prisons or jails. And most of my work centers on vulnerable populations such as those.
Perfect, thank you. And next we have Matthew Rose, who is a longstanding HIV and social justice advocate, currently serving as the Director of US Policy and Advocacy at the Health Gap. Yes, Matthew, if you'd like to talk a little more.
Yeah, thank you so much for having me. Always happy to talk to young people about how they can get involved in the movement and the work. So many of us come up from our passions that we learn in college and continue those on. How I got involved, it is how I got involved with HIV, started working at a local AIDS service organization. And then 10 years later, I was doing federal health policy on HIV, and now I do global HIV. In all honesty, it's actually all global because no country can really quarantine off its HIV. So it's all kind of connected, and we're all kind of looking for the same stuff. But I primarily work in community spaces and getting policies to help make lives better for people living with or vulnerable to HIV. And we'll leave it for there for now. I'll leave some of the bulk for the other questions.
All right, beautiful. All right, beautiful. Okay, so our fourth panelist, I don't think is here yet, but his name is Dr. D'Angelo Lawrence. He is the director of the Burgess Clinic, which focuses on serving HIV behaviorally infected youth, and also is the director of the Youth Pride Clinic, which focuses on serving LGBTQ youth. If he is able to come later on the event, we'll definitely have him jump in and do his introduction. But okay, so we are so incredibly lucky and excited to have such an amazing board of panelists for today's event. For any of our attendees, if you have any questions while the panelists are speaking, feel free to put them in the chat. You can also privately message them to me if you'd like me to ask them. And we will also be having the Q&A session at the end. And so with that, I'm going to pass it off to Morgan to ask our first question.
Hi, so I'm Morgan, and just a little context for the way the panel section is going to operate. Each UAEM member is going to ask one question, and due to the content of the question, we're going to pose it to one panelist first. So the first question we're going to ask is, what are some common misconceptions of HIV and AIDS, and how do they impact access to resources and treatment for patients? And I'm going to pose this one to Dr. Farrell first. So whenever you're ready.
Like Tiffany said, you'd think I'd know by now, but not so much. And the only reason I'm muted is so you wouldn't hear me gulping water. So there are a lot of misconceptions, and I think that these have evolved over the years, but it's amazing how persistent some of them have been for decades and decades. Starting with the misconception that HIV is something that centers around specific populations, that HIV is something that is a death sentence, which I think is a very harmful misconception, because I think it prevents people from having hope and in having confidence for themselves, and in cultivating skills for self-actualization and empowering themselves to take action. I think there's also a lot of misconceptions about contagion and stigma. And I'm sure that we'll delve into U=U later on and make sure that everybody here knows what that is. But I think that people thinking that not only are they contagious, not only are they themselves at risk of dying, but that they could spread this to other people, I think also really erodes at confidence. And when other people find out somebody's status and they treat them accordingly, I think that can be incredibly harmful as well. And I think there's also a misconception that the medications are toxic. I think there are these old perceptions of what antiretroviral therapy really is. I think one of them is, we used to talk about HAART, highly active antiretroviral therapy, And there was this idea that it was somehow supercharged, that it was going to be worse than actual antiretroviral therapy. And all antiretroviral therapy is highly active now. We don't talk about highly active antihypertensive therapy. It's just antihypertensive therapy. So I think that kind of normalizing antiretroviral therapy, just calling it antiretroviral therapy the way we would any other set of medications, and giving people the confidence that really there's no more side effects, no more toxicity than any other class of medications, helps to kind of bring HIV into the sphere of things that people feel like they can manage and talk to other people about.
Thank you so much for that informative answer. And anybody else is welcome to go ahead and answer that same question. It's just a little easier if we pose it to one person first. So,
Perfect.
I mean, I would say that a lot of time, especially on where you are and who you're talking to, there's an assumption that the epidemic is over. In the United States alone, there are still 36,000 new infections every day, every year. Thinking my global numbers again. Globally, we have very sad numbers. Every day, there's 500 babies born with HIV, which is a 100 completely preventable transmission event. We have 1.9 million people seroconvert every year globally. And, you know, as Dr. Farrell was saying, we have gotten so much further and so much better. I just got to talk to people the other day about, we've now taken antiretroviral treatment down to 1 pill a day. We are now looking at 1 pill a week. We've got a shot a month. We are really breaking new ground that we haven't before. And we're actually starting to have, I think, which is a really important conversation, and Tiffany will probably tell you that go on and on about this, but it's really looking at what are the factors that make people vulnerable to HIV. And so what are the experience of housing, education, poverty? And that is really what helps drive this thing. One of the, in Eastern Kenya, we found one of the most protective factors for protecting young girls from getting HIV was them finishing their primary education. Had a 64% decrease in potential HIV infection. And so we've learned a lot of really important things, and some things that we've known for a while about how kind of social structural roles play a part in people's lives, and people have done some great research on that, but we're starting to scale that up and actually how to influence people's lives. And I think things like the Ryan White program are a great example of us scaling things up, but so important to recognize that it's not all over. It does still exist in some populations. It's going down for some groups and it's going up for others. And it's still our lived experience until we, put in the last of the work to get that last mile.
Absolutely. I have to agree with both of my esteemed panelists. And one of the things that I want to say as well is that, because I'm glad that Dr. Rhodes did talk about the social determinants of health. I think, originally it was like, okay, there's something that someone does to put them at risk. We use these terms a lot. What are the odds, this and that and the other thing? And looking at some of the structural barriers and things that we really, really need to grapple with, I think, I will say as a country, but also globally, right? In order to really have an impact on HIV. One of the things that I think is really of interest to, I would say me, and something that I've tried to figure out sort of what it means, and that's that people are resilient, right? And so in thinking about, what do we, I think about like epidemiology, like, so what are the risks? What are the odds? What's this? What's that? And it's like, there are people who are living. So we have an aging cohort of folks who are living with HIV. They've been living with HIV for 30 years. My father was diagnosed with HIV in 1995 and recently passed away. And he lived for a long time, right? And so it's like, what are some of the things that we can actually hold on to, that we can really build communities and make communities who are most susceptible stronger, so that they can feel like, I think Dr. Farrell said this, like it's not a death sentence. So what do we need to do so that we can be whole as a community, right? And not always think of this as something, but it's a whole plethora of things that people are trying to live through. We've got COVID, we've got unstable housing, we've got criminal justice involvement, we've got this, we've got Black Lives Matter, we have this and that and the other thing. And it's HIV is one of them. So how do we make people just whole so that we can have a well society in general?
Wow, thank you so much. Just with that first question, I'm just already so excited. Thank you so much for sharing your thoughts and insights. So before we move on to the second question, first I realized I forgot to spotlight everyone, our beautiful panelists. So I'm going to quickly go ahead and do that now. Hello, okay, add spotlight. All right. And I believe our fourth wonderful panelist is actually here. Hello, Dr. Lawrence D'Angelo.
Hey, how are you?
Hello, I'm good. Let me go ahead and add a spotlight. Perfect. If you want to go ahead and give a quick 1 or 2 minute introduction, just about your work, what you're passionate about, a little bit about your story.
You know what? I'm going to have to sign off.
Oh no, I think I'm hearing a little bit of an echo. Oh, yeah, okay, that's okay. We can give him a couple of seconds to join back in. If not, I believe we can move on to the second.
Here we go. No, I think I'm here. I was trying to game the system a bit and use my phone for the audio because I wasn't getting regular audio on my computer, but now I'm getting at least a regular connection. I'm Larry D'Angelo. I'm a faculty member at George Washington University, but I've spent my career, and it's longer than I'm going to admit to anybody. I spent my career at Children's National, where, and believe it or not, in 1988, I created something called the Burgess Clinic, for HIV-infected adolescents and young adults, which was in existence continually for 31 years. And just this past June merged with the Special Immunology Service, which is our children's service for, used to be children's service for younger HIV-infected individuals. And so it's been a long run. And I've seen virtually every possible imaginable change in this epidemic. And quite frankly, have been so gratified to see where we are now. And unfortunately, also so disappointed to realize that we are still in the midst of the battle. Now my main responsibility is to serve as the director of the Youth Pride Clinic, which is directed to the LGBT and in particular T youth who come to Children's for healthcare services. As could be imagined, certainly some of our preventive services are focused on many of the kids in the Youth Pride Clinic.
Perfect. Thank you so much. Thank you so much for joining us today. Just also to give a little context, I would love to pin Dr. D'Angelo, but I think because there's no camera involved, I don't see the option to spotlight. But so sorry, just to give a little context about that.
There we go.
Oh, perfect. Okay. Perfect. Add spotlight. There we go. Amazing. Okay, with that, I'm going to pass it off to Priya to ask our second question.
So our second question, and we'll start with Dr. Daya for this one, is are there any communities or groups that face additional barriers in accessing treatments and care for HIV and preventative measures? And if so, what are those measures? What are those additional barriers, and what measures do you think should be taken to try and limit them?
Okay, that's an excellent question. I would definitely say, so we have a PRC at the University of Maryland. It's the only one that focuses on LGBTQ plus mental health. And so I would definitely, that's a good question, but it's tough for me because I try my hardest not to sort of single out particular populations, because I think that there's more to it than just you belong to this particular group. I think there are more, some of the barriers are barriers that, people of color, again, sexual gender minority folks, deal with. So I actually did just single out people, but it's more around not the fact that you just belong to one of these groups of people. It's more or less sort of the social structural barriers, right? So dealing with unnecessary discrimination and intersectional stigma. So stigma around, first of all, maybe having HIV or maybe even being at risk, right? So the things that we talk about, even in terms of being eligible for PrEP, you have to fit a certain sort of profile in order to even be eligible, right? And so even with dealing with, I'll say like Black women in Prince George's County, which is a very affluent area of Maryland, you know, a lot of the women are just like, well, I'm, you know, what are you telling me if you're asking me about, you know, do I know about PrEP, or am I taking PrEP? Have I, you know, just, so even dealing with sort of I'll say stigmatizing people because of the way that the virus was labeled at the outset in 1983 or so, that hasn't gone away. And so it's unnecessarily stigmatizing, discriminatory. It adds layers onto people's lives that it's like, okay, I'm already Black, I'm already old, I'm already poor, I'm already this. So then there's this extra other thing. I think that we need to address the barriers and not address the people. I don't know how to say that without sounding like, well, how are we gonna do that without just people? But not like blaming the victim kind of thing, and really talk about some of the structural factors in this country and abroad and globally. I think Dr. Rose would also say, like, this is not just something that's, you know, germane, you know, to being in the United States of America, but thinking about how do we undo some of the things that have been done to specific populations that put them in boxes that, you know, where you know, we do find ourselves at higher risk for whatever reason. Dr. Rose was just saying that, you know, the number one sort of preventive thing was having post-secondary education. Like, that seems like something that's so simple. That's so simple, right? But it's like, how do we actually enforce that in communities and in populations and in counties and in countries so that we can just give people a fair shot at whatever, you know, their lives are going to be. But then part of me wants to say, again, like I said before, people are resilient. You know, I think we have, you know, the human resolve is such that, you know, we're going to fight. We're going to do our best to be the best that we can be. And so sometimes that means, you know, taking a stand. We've got advocates, we've got advocacy, we've got clinicians, we've got epidemiologists, we've got community folks, just people who are doing, like, it takes all of us to really address what those barriers are, because the barriers aren't with the people themselves. It's the structure of things.
I think those are really fantastic points. Am I allowed to talk now? Just wanted to comment on one thing. So I think focusing on specific populations sometimes prevents us from seeing the big picture. And, you know, sometimes we have these goals to try to focus on one particular population that we think is having trouble accessing care. And while we end up doing a lot of good, I think as those projects evolve, sometimes we miss things that are right in front of us. One thing that I think is really helpful is thinking about some of these issues within a structural framework. And if you're not familiar with structural determinants of health, it's looking at all of the layers that impact an individual's health, starting with the country that they live in, starting with our world even. So we could look at environmental factors like air pollution. We can look at the, you know, the government that the person lives under. We can look at the type of country that they live in, what the leadership is like, all the way down to the type of neighborhood where they live, the proximity of high quality food and transportation resources, their access to education, their access to clean water, and then look at their social supports. And one of the major risk factors that I see in our clinic for poor outcomes is isolation and loneliness and untreated comorbid mental health conditions. And oftentimes a lot of the things that Tiffany was describing have actually led a person to a place where they're maybe already isolated, where they maybe already are in a situation where they don't have as much support, and adding HIV on top of that, or revisiting the diagnosis of HIV, if that was made a while ago, can sometimes make for a really complicated clinical situation, and a really complicated social situation as we try to navigate figuring out, not only can we get this person to clinic, can we prescribe them their antiretroviral therapy, but can we keep them coming back? And our standard is to have somebody have an undetectable viral load, but what does that really mean if your quality of life is poor, if you're not enjoying your life, if you have, an ulcer on your leg that won't heal, if you're hearing voices, if you don't have enough to eat, if you're miserable? These things are also really important.
I would just say, because I'm that guy, you got to talk about what is pleasurable to people.
Mhm.
Talk about what makes people happy. Sex is
Yes.
pleasurable and enjoyable.
Mhm.
Let me teach you some things that can make sure your sex just remains pleasurable, enjoyable. Clean
Yes.
needles feel really good. That's why
Okay.
people love needle exchange. We have to kind of destigmatize those things.
Mhm.
If I had to look at a particular population, I think what's already been said is correct. Like some of these structural barriers and making sure that there's actually equity and parity are going to be really important. We've got to do better around the trans community, especially Black trans women. But there are a lot of these things are societal ills that you could work on without HIV. HIV just
Yes.
likes to conveniently hop on top of these things.
Yes.
And so if you worked on someone's housing, that also reduces their HIV risk, or it makes them more likely to take their medication. Surprise!
Right.
So, and then just stigmatizing, we gotta stop stigmatizing people's lives. Let people play the sex they're having, what they do is pleasurable, and how you can make them have better health outcomes as a result. And everybody wants to have better health outcomes, especially when you can make it sound fun. So that's where I go.
Yeah. I think that we can be hopeful. And we can be hopeful, interestingly enough, probably only in the past couple years, that we might actually be able to now begin addressing some of these structural barriers. For years, we've sort of known they've existed, but we haven't really had a mechanism for approaching them. And I think that now, hopefully, through the trauma that we've been through over the course of the past couple of years, we can begin to say, well, there's a major cause of a whole variety of adverse circumstances in the lives of people. One of my patients last year, and just as I was informing him of his diagnosis, sort of looked at me and I said, well, how can you share with me what this means? And he looked at me and he said, with a smile on his face, and he said, Dr. D'Angelo, he said, that's about the fourth worst thing in my life right now.
Mm-hmm.
And, so that people are living with so many other disadvantages that we've imposed on them, that, taking their illness and trying to separate it out and say, well, yes, we're going to treat your HIV. Well, of course, we're going to treat your HIV. But quite frankly, if we aren't going to address some of those other issues, we aren't going to get to where we need to be. We aren't going to reduce our new caseload below 36,000 a year.
I think that's so true. And I think, especially for the students here, I think, going back to everything that's been said about helping to understand what's important in people's lives, and kind of what makes them tick, and asking what those things are that are more important than an HIV diagnosis is so critical. And you guys are lucky because you've grown up being more comfortable talking about some of these things than I would guess the four of us have. But practicing asking people about their sex lives, asking people how they use, and keeping an open mind will help you get those answers. So I think even just knowing that those things exist is critical.
Yeah, that was great. Thank you so much, guys, for all of your wonderful responses. And now for the next question, I'm going to direct this to Dr. D'Angelo first. So what are some of the most effective interventions that currently exist to address the HIV/AIDS epidemic?
Well, certainly, you know, first of all, let's talk about prevention. And we can certainly talk about the medical interventions. And now we know with the introduction of PrEP, we have a major piece of our armamentarium that can prevent infection in individuals who may have the untoward consequence of coming into contact with HIV. And, you know, from whatever source they may come in contact with it. So I think that from a preventive standpoint, PrEP is huge. And it certainly beats all of the other purported behavioral interventions that people have touted in the past. In terms of the actual treatment and therapy of individuals, you know, as was mentioned earlier, gosh, our medication regimens now that we have available are phenomenal. You know, if you can get someone to take one pill once a day, we're now at the point where we're going to be able to say, if we can get you to take one injection once a month, that, you know, we are going to have a wonderful opportunity to control HIV infection and really sort of eliminate it as a potential determinant of what the rest of your health is going to be like. So, you know, we've made great strides. The areas where we still haven't made strides, however, is, well, you know, how do we change the fact that people come in contact with HIV? Or if we aren't going to change that fact, how do we ensure that we're going to make preventive treatment available in such a way that everybody can have access to it?
Well, I was going to kick it to Claire because I thought the opening for U = U was right there.
It was, I know. I feel like I've been
Everybody's eyes were like,
yes, I know, that was like the perfect
the moment.
Yeah, you should talk about it.
Oh, no, I got so many other interventions.
There's
I mean,
so
like
many good interventions. How many?
Needle exchange. Whoa, wow, it works.
It
Simply
does.
giving people clean needles, highly effective, very cheap. We're trying to get rid of the last piece of federal legislation or federal law rather, that blocks us from purchasing needles, but that's like the cheapest part of the program. But even southern states will talk to you about needle exchange. West Virginia will talk to you about needle exchange. Well, only because they have a huge opioid number that's caused them to have a lot of HIV and a lot of hepatitis C. So now they're willing to talk to you about needle exchange.
North Carolina, we're in a battle with the North Carolina legislature right now about this.
They love me some needle exchange. I also looking down the pipeline. So I love the fact that we have a shot once a month for treatment, but I also work on the research side. So I know that we are also working on a shot. We're actually, no, even better. There's an implant for once every 6 months and a self-injectable shot for once every 2 months that we're working on, and a pill for once a week instead of every day. So lots of like really crazy stuff. And of course, on the prevention side, shout out to my vaccine friends. We are still in the crazy COVID environment. We are still working on an HIV vaccine. The trial is ongoing using the same platform technology that we use for the J&J vaccine. So lots of stuff in the research pipeline. I'm biased because I do stuff for the Microbial Trials Network. And by do stuff, I mean I'm their community liaison, so I sit on all the protocols to represent community. We have some amazing research coming out with a vaginal ring that lasts 90 days that has both an ARV for prevention and a hormonal contraceptive, because women should only have to take one instead of like two, or like a pill here and a poke there and a jab there. No, let's consolidate.
Yeah.
Still, one of your best ways of fighting HIV is having education, ramping up education, getting people housing, it's the most requested service, getting people housing before they seroconvert.
Yes.
Getting people healthcare, one of the best pieces of policy that we got in the last 10 years, one of my favorite pieces, I won't say the best, one of my favorite pieces out of the Affordable Care Act, it's possible to use Ryan White dollars to, instead of buying medication, you can now buy people health insurance.
Yes.
This means you can get them in primary care for everything else and coverage for their HIV medications.
Yes.
So
Yes.
there's some great new learnings, but one of the huge problems we have is getting all of that stuff told to people in general and like democratizing that knowledge.
Yeah.
And we've struggled with that. You can look at the fact that we have had PrEP in this country since 2012 and still are lagging in every indicator. Women don't barely know they can use it, let alone like, and why am I using it? We still, to this day in the United States, we still have babies born with HIV, which is something we know we can intervene against, because the basis for making PrEP was based on the concept of intervening against vertical transmission.
Yes.
And so we can be doing better. And as we close some of those gaps, I get really excited, but also just like, there's a whole bunch of science coming. And I will say that everyone will tell you, some of the biomedical people will tell you that everything is cool and biomedical. I will remind you that everything is biobehavioral, because at some point, someone's got to show up to that clinic, someone's got to take that medication, someone's got to make that appointment, and all those things are behaviors.
You literally, that was, okay, I have nothing to say. Because I was gonna say, so while we're talking about biomedical interventions, we have to talk about behavioral because you still have to do it, right? And so I think education, like you're saying, is like, just how do we educate folks and then take care of some of the other structural and social barriers so that people can just, that's only one thing for people to focus on. I think there was a paper that was written, I was in my PhD program, so it had to be like 1900. And,
thereabouts.
Back in those days. And the paper was called, it was like literally, HIV is not my biggest problem. And I was like, what? Kind of thing. And so we walk into these settings and it's like, let's talk about your HIV. And it's like, I think we're all kind of saying the same thing, which is like, let's talk about you, like as a person, and like how we can help you just navigate whatever it is in your life. HIV is one of them, right? And so I think people going to the clinic, people being able to engage in PrEP, it requires that they even have just the mental space to even just to do it. Like it's hard. I think during COVID, we've all seen this where we've all, everything shut down. It was like, okay, this is something. And it was like, okay. And now I see my students and it's like this cumulative stress. And it's like that they weren't this bad in fall. And now it's just like, they're just really struggling. And I think we all are in a way. And so it's like mental health is key in terms of how we can just, just help people in general.
It's so important also to reduce the friction in those systems. I mean, I think, we've all had anxiety about, if you go to see a new healthcare provider about something and you don't really know what to expect, it's a new clinic or it's something that you're very worried about, or you had a friend who had it or a family member. It can be very, very stressful. And we have had much less PrEP uptake in our general community. And I think that's part of it. People don't really know what to expect when they go to see somebody. And I think the path to utilizing PrEP more, which is Matt laid out, is just one of our many tools, is to have a clear lead in from another medical encounter. So to empower everybody to talk about PrEP. So sure, if you go to see a primary care person, if you sprain your ankle, if you do anything, to have everybody prepared to talk about PrEP, but also, school counselors and community centers, YMCAs, to have it be something that's a little bit more normalized. One of our dreams was to have sort of a pathway to PrEP for people who sought care after a sexual encounter that was either an unwanted sexual encounter with an HIV exposure, something that was impulsive and they later on kind of worried about their risk, something that they didn't have complete agency over that maybe was transactional, anything. But, a lot of people don't realize that you can take medicines to prevent HIV after a sexual encounter if you access them within the correct amount of time. But ideally, once somebody has taken those, there are very few people who would not be appropriate candidates for PrEP or to at least consider it. But we've managed to separate those types of encounters, and this is getting really granular, but we've separated those types of encounters into silos. And so it takes somebody recovering from the trauma of having to take HIV prevention medicine and then muster up the courage again to go access something that they can take daily or hopefully eventually monthly or less seldom or less frequently.
Oh, I forgot one of my favorite interventions.
Yes.
It's automatic opt-out requesting form for an HIV test when you show up at a provider space.
Mhm.
If it's just in the electronic medical record, it just
Yep.
says, oh, you don't have a test on file in the last year? Well, we're going to order a
Go.
test unless you want us to opt out of it.
Absolutely.
Mhm. We just started doing that. It's kind of amazing. Yeah, no, I think it's really important. What are we forgetting?
We
There's
didn't
so many
explain U
great
equals
tools.
U.
Oh, no, we didn't. That's right. Thank you. Okay, so U equals U. A lot of people have not heard of this. If you guys, I can put this in the chat later. There's a great website called the Prevention Access Campaign that's full of, it's basically a clearinghouse for all the available scientific data and social media campaigns and explaining videos that all speak to sort of one central message, which is that if you are taking HIV medicines and you are what's called undetectable, meaning that we don't see the virus in your blood, you cannot transmit the virus sexually to another person. If you have sex with somebody, it's really good manners to tell them that you're positive, because sometimes people don't like it if they find that out after the fact, but you're not going to give it to them. And so it's critically important that our patients understand this, because a lot of patients have sort of closed off parts of their lives or parts of their hearts over time. And you know, I don't know, some of my conversations with my aging patients have been among the most profound in this regard, where people received a diagnosis, you know, in the 80s, the 90s, even the 2000s, and you know, received a message that they were truly a danger to other people, or that they could never hope to have kids, or that, you know, this was something that they had to sit down and have a very serious, tearful conversation with partners about. And or they just really feared making somebody else sick. And we found through these huge studies with, you know, hundreds of thousands of people now, an accumulation of studies that show that if you're undetectable on HIV medicine, you're not going to give this to somebody else. And it's been one of the happiest parts of my career as an HIV clinician to be able to talk to people about this and all the other cool stuff that Matt was talking about. So I'll put that website in the chat so you guys can take a look at it.
Thank you all so much for your responses to that question about like no needle exchange and PrEP. It's all really interesting stuff that exists that, you know, not all of us knew about. So thank you. And so I'm going to pose this last question to Mr. Rose, and it definitely ties in a lot to the answers that you gave to the last question. But what we're wondering is, based on your own research and experience, what policies and methods would you recommend to address the HIV/AIDS epidemic? And this can be policies that are already in practice, or policies that you think would be a great idea that's not really widely used in practice yet.
So old school, and by old school I mean not that old, because in June, for those who want fun dates, June 5th is the 40th anniversary of the MMWR paper that announced what we now know as HIV to the world. But in 2011, David Holgrave and I were having a conversation about what a full whole care system to provide for psychosocial, structural support for an individual would be to keep them in care. And Ryan White does some of it, but not all of it. It doesn't have quite the reach that we wanted to have sometimes. It doesn't quite have the flexibility on transportation, and it can't do long-term housing. You have to go to another program to do that. But the prescriptions from that policy paper have helped shape how we think about what it means to have comprehensive care, how care is not just someone show up at the clinic and got a lab draw, but that you actually have to ask them about, you know, where are they at, just where's their mental health at for the moment? Do they have the ability to access medication? Do they want a specialty pharmacy mailed to them? What else? And having this whole comprehensive look of people, and then making that more prevalent and proliferating in as many places. And also figuring out where are ways people can get care. So how do I get to a doctor and how do I make it easier? And how has we fought, so every year, the HIV community, thanks to the Affordable Care Act, gotta love it, has a independent clause of action that allows us to sue or challenge any plan that is sold in the marketplaces for discriminatory practices. So in our mind, anything that would make it, we think would make it harder for our HIV person to either use that plan or spends too much money on that plan. So usually it's around, they want to limit the amount of medications because they're like, oh, medications, can't they just take any pill? I'm like, no, it doesn't work that way. Let me tell you about mutation. But there are things like that that we use every year that are highly useful pieces. What we learned from the Key Populations Investment Fund, which is a program that we ran out of the PEPFAR program, which is the US's big flagship global health program, works in 15 different countries, beautiful thing. What we learned from that is that just having key population organizations exist, really helpful. So supporting drug user health communities, civil society to exist, sex workers, LGBT folks, and other queer folks, and just having those organizations around and the presence of them, really, really helpful. Fighting laws that discriminate against and removing. So we've seen about 8 or 9 states change or modernize their HIV criminalization laws. Some of those laws are super terrible, where they say, if you just didn't tell someone you were HIV positive, and by tell, we mean if you didn't like record and have a legal signing of the document, you could be prosecuted. And those still exist in too many states, but all of those are just kind of great legal changes and policy prescriptions that have really moved the needle forward. And also aligning funding with your local epidemic. So what is happening in Maryland is not what's happening in Baton Rouge, what's happening in Gainesville, what's happening in LA. And so we try to make it so that funding is more proportional to what you're seeing in your local epidemic, and making sure that community has to be involved in those funding decisions. And I'll leave that.
Those are really critical points. The transportation piece really hit a nerve. One thing that we've tried to do with our Ryan White funds that we were finally successful with just in the past year and a half, and then we're able to ramp up during COVID, is using funds for a sort of a medical Uber service that's bonded to take patients to and from medical appointments. But I'm not patting myself on the back here. The amount of paperwork and the amount of sort of rebudgeting that it took to even make that service accessible to a small number of people is staggering. And you know, I live in a state that has an interesting mix of rural and urban sort of sections that we serve, and navigating transportation across these places is really tough.
Mm-hmm.
Dr. Dyer, did you have something to add on to that? I know that you.
I don't know. I'm just thinking. I'm just thinking about just everything. And I think one of the things that I would like to add as well is, and I think it just kind of sort of dovetails off of what has already been said, and that's providing these wraparound services for people, right? And so it's not just putting a Band-Aid on one thing. It's starting where the people are. So it's like, but you've got to know your population. You can be willing to step out there and really take a risk and say, okay, what is it that this person needs? And so like Clara is saying, like, is it transportation? Is it housing? I think we've all said this. It's like, how do we provide services that really meet people where they are? And so it's not just one aspect, but it's every aspect of your life. And again, we've got how many people that we need to deal with. So I know that's hard to do. So that's why it's sort of like the policy implications of all of these things. It's like, how do we do this in a real world setting? And I think what Matthew said is what we do. It's sort of like really, you know, putting on a lens of putting yourself in the shoes of folks who are, and looking at yourself as well, and thinking about, you know, me as a Black woman living in Maryland, like, what is it that I would need in order for me to be as healthy as I possibly can, or reduce my risk for HIV, or do whatever it is that I need to do to be a whole person. And so I think that means providing these wraparound services that do going back to the second question that we had, like who are the populations that are most affected? And so without stigmatizing folks, et cetera, we do want to talk about the entire queer population, talk about people of color, people who are underrepresented, underserved, marginalized, the rural population, just thinking about other things that require that we really just take a step back and use, I'll say an interdisciplinary, but just sort of multi-level sort of, I don't want to say methods because that's not the word but that's the only word that comes up. Just sort of these multi-level, I'll say interventions so that people can really be met at these different levels of their lives. Personal, psychosocial, structural, social determinants of health, financial, economic, just everything, just wraparound services for people.
And those can look different in different places. I mean, I'm sure their clinic offers different things. I did my training in Boston, and a lot of the services that we were thinking about were focused on, sort of a hyper local population where a lot of our patients were coming from neighborhoods surrounding our hospital. And it's a very different thing, working in North Carolina. It's a very different thing for our providers who focus on youth. They use tools that maybe wouldn't be appropriate for older populations. So it's not just sort of figuring out a medical Uber system and patting yourself on the back. It's figuring out like, how does that work for somebody who doesn't have a phone? How does that work for, a younger person who, is worried they're going to know the Uber driver?
Certainly, yes. Thank you so much for sharing all of your insightful answers. I do want to open it up to everyone who's attending, just to go ahead and move into our Q&A session. So if you do have a question, feel free to raise your hand or just unmute yourself or put something in the chat.
Hi, so I had a really quick question. I'll also thank you so much for speaking today. It's been really insightful. So you guys were talking about how there's been really great innovations in HIV treatment and how it can become undetectable and people can live really manageable lives. I was wondering how that looks for HIV populations who aren't in the US. So looking at like the global South and countries that may not have access to certain treatments and how we go about looking at, interventions abroad. Yeah.
So that is one of the great things that President Bush, well, we give him credit for because it makes it easier for everybody, did, is waive certain intellectual property rights, which we're trying to get right now on the on the COVID vaccines, but we allowed antiretrovirals to go to generic manufacturers, particularly coming out of India, which is now going to have a whole bunch of other implications if we don't help India get things under control. But the United States government alone through PEPFAR supports 17.2 million people on ARVs worldwide. There are 38 million people living with HIV, last estimate. And then through the Global Fund to fight HIV, TB, and malaria, you've got another 10 million supported. So we are doing better. And actually, a lot of countries, there's this kind of cascade we like to think about. It's called it's a treatment cascade. So it's 90% people know their HIV status, 90% people know are in medical care, and then 90% of them are virally suppressed. So across the 90s board, a number of other countries have gotten to their triple 90. The United States is about, I think it's 84, 79, 62. So we're not doing that great on our own, but there are a number of countries. My favorite is Botswana and Lesotho have done an amazing job. Eswatini all have done amazing works on their cascades. But about 40 countries have moved towards significant viral markers in getting to that triple 90. And then we'll eventually, as a world, move from 90, 90, 90 to 95, 95, 95. That 5% you always just kind of have to write off because you never assume that your programs are going to be perfect. But we are making strides. It is challenging for mainly gay, bisexual, and transgender individuals. And for children, we're not great at children for a number of reasons, but so the global picture, we are making progress, and a lot of that is led by the United States.
And, you know, it should be. We're a rich country, and we have people like Matt who can be leaders in this. But at the same time, the answer is never to go somewhere for a little bit and dump a bunch of medicines or take care of people and take pictures and then leave. You want to create durable infrastructure, and you want to create sustainable programs. And so that's the other big thing that underscores this. So, you know, any help is great, but as you're thinking about things, as you move on in your career, thinking about things that are sustainable and aligning yourself with organizations that have longstanding presence and that have a mission of education and training for people who actually are native to that country is really critical.
And that's very true. A lot of my colleagues are in Eastern and Southern Africa. And one of the things that is always amazing is whenever clinics get open, those clinics are not staffed by Americans.
Right.
Those clinics are staffed by local people,
Mhm.
local doctors who get trained, who come back, healthcare
Yes.
providers who get trained and stay, community health workers. And it's really about building infrastructure in those communities and things that are going to stay. And we do it on the research side too. We're like, you can come do your HIV study, but we require you to build this health center and then leave it to us. Thanks.
And make people who are native to that country co-authors on the study, so advance their academic careers and help to stop the brain drain in, you know, places where I've spent time. And I don't pick favorites among countries. I don't know what Matt's doing, but no, I'm just kidding. But you know, it's critical that people also have a reason to stay. And a lot of places are really tough places to practice medicine and to work. And you know, it can be much more attractive to go and live and work in a first world country. And we have to try to create a situation where people don't immediately get burnt out or don't see a future for themselves clinically. And having more feet on the ground who are well trained makes a huge difference. That was a long answer to your question.
It was a perfect answer. If nobody else has any other questions, I definitely do want to be respectful to our panelists' time. So we can move into our closing remarks. Before we do that, I just want to say that everyone's passion and energy was just so infectious at this panel. So thank you so much. Believe it or not, this is actually my third panel of the day. It's a very popular Zoom online event. And this by far was my favorite. So just wanted to say my thanks there. And I'll go and pass off to Megna to do our closing remarks.
With that, we would love to thank our 4 spectacular panelists who have dedicated their time to join us today to discuss their insights and share their extensive knowledge about the HIV and AIDS pandemic. This issue has been quite devastating for many members of the community and many individuals, especially during the past few decades, and addressing this topic is incredibly crucial to spread awareness to the general public and influence policies surrounding the subject. Each of our panelists has been incredibly inspiring in their efforts to ameliorate the situation through their research and treatments of patients who are impacted by HIV and AIDS. And thank you to all the audience members as well. We were so lucky to have you attend, since I know it is pretty hectic with final season, and we hope you were all able to learn more about the HIV/AIDS pandemic from this panel. Once again, we really appreciate each and every one of you for all that you do and for contributing to this panel and playing an integral role in attenuating the devastating impact of HIV and AIDS in our nation, and overall just establishing a better society by thwarting the virus and ensuring that it no longer plagues our nation in the future. Thank you, guys.
Thank you, everyone.
Thank you, everyone. I just want to say too that I learned something, and I love that as well. You know, I just always feel like enlightened, very esteemed. I keep saying that, panelists and colleagues and people that I haven't been able to lay eyes on personally for a really long time, but I promise to reach out to you. But I learned a lot today, so I appreciate your time as well.
Likewise.
This is my yoga, my flower. This is what. Have a good night.
Thank you all.
Thank you all.
Everyone.
Thank you.